Welcome to the Cogitate podcast. I'm Harry Crisp, and today I'm speaking with Tushar Srivastava. Tushar has a Bachelor of Medicine and Surgery from the University of Auckland. He's been working in Auckland hospitals on the COVID response team during the outbreaks in New Zealand, and as you'll hear, that's been fairly uneventful thus far. We talk about how COVID affected hospitals in New Zealand, the Quack field of chiropractics, homeopathy and the placebo effect, the overworking and underpaying of medical staff and how the nurses' union is regularly threatening to go on strike, and we discuss the plant-based diet and weight loss. As this is the first podcast episode I've ever recorded, there are some audio hiccups, but we figured it out about 10 minutes or so in, and I've edited around the worst and improved it in post as much as I can. But apologies if you notice a few bumps along the way. This episode was recorded in late January 2022 and will no doubt be released some weeks later. At the time of recording and prior to, New Zealand had largely avoided a large outbreak of COVID, but Omicron is at our doorstep. It is yet to be seen how the hospitals fare against Omicron. Without further preamble, I bring you Tushar Srivastava. Okay, I am here with Tushar Srivastava.
Nice work.
Did I get that right?
Yes, you did.
Thank you for doing this.
Yeah.
Last night we had an interesting conversation where I told you about how as a child I went to a chiropractor appointment. I had scoliosis as a kid, or I had back problems that was later diagnosed as scoliosis. And so I went to see a chiropractor and I found that their treatment for my back problems was so minor as to be surely accomplishing nothing. They essentially lightly pressed on some areas of my back in a way that I thought could not be accomplishing anything useful. And then you went on to tell me how illegitimate the practice of chiropractic is. And I was completely surprised by that. So do you want to talk a little bit about the field of chiropractics?
Well, I mean, like, as a health professional, if anyone asked me about advice with from should I go see a chiropractor, I would say no. I would never, in any situation, I would say no. And I guess the only reason for that is because, one, their philosophy, and two, it's not evidence-based medicine. Now, when I say evidence-based medicine, it literally means that any treatment that we do, or any treatment that we do, any investigation that we do, is supported of some type of literature and evidence. And there is a method to the madness, right? Whereas when it comes to being a chiropractor, their original philosophy is that they can treat any ailment. So, like we said yesterday, if you have rib pain, like you said before, they can fix it by cracking your back.
What about fungal infection?
Yeah, a fungal infection, they can fix it by cracking your back. And anything that they do is not evidence-based, which is terrifying. And I guess it's a specific issue in New Zealand because I know people who do the practice and they call themselves doctors, which is insane because there's no title given to be a doctor, who's a chiropractor. And it's terrifying.
So they've essentially received some standard education that is not doctorate level, yet they walk around putting a doctor title in front of their...
And let me be clear, like as someone who is so I've done medical school, but the degree that I get is a Bachelor of Medicine and Surgery. So it is a bachelor's. I am an intern and a house officer, and I'm considered as a junior doctor. Have I actually received the doctor title as a physician? No. And I don't go around saying that I'm a doctor yet. But at the hospital, it's routine to just be identified as a doctor. If you want to be a full trained doctor, that takes probably 12 years plus of intensive work and study to get your postgraduate and become a consultant. And that's when you're considered as a doctor. When you're a surgeon, you change from a doctor to a Mr.
Sounds like
Mr. or Miss.
Huh? It sounds like a demotion.
Well, yeah, it does. The reason why surgeons are considered Mr. and Miss from my memory, is that the most original doctors were barbers. Barbers were, so there were no, you know the blue, white and red?
No.
In a barber shop right outside.
Oh, yes.
Yeah?
Yes, the spirally thing.
The spirally thing. I can't remember what the blue was, but the white is supposed to signify cotton and the red is supposed to represent blood. They did a lot of drainage. So let's say you had an infection or specific disease, they would drain the blood by cutting. And so those were the most like archaic forms at the very beginning. Obviously they didn't receive much respect because the stuff they did was quite barbaric and most of the people died because it didn't really have any evidence to what they did. But that's how surgery originated. And that's what barbers did. They cut hair and they also did all that other stuff as well back then. And so once you become a fully trained surgeon, your status changes from doctor to Ms. or Mr.
Interesting.
Yeah. But I'm going back to chiropractors. It's genuinely terrifying. I mean, there's a little bit of common sense that's involved, right? I can understand. I know a lot of people go towards to chiropractors and people defend their specialty and what they do, and people say they have received some form of a benefit.
Anecdotes,
right?
Very much.
Yeah. So I can say some situations where sometimes the medical profession can't provide treatment for some people that have back pain or specific back pain issues. And it sucks, right? Because you've done everything you can and the last resort for you feels like you're going to a doctor, you feel like they can fix it. But sometimes we can't fix the back pain. And for them, their last resort now is going to the chiropractor. And I feel like they use that in terms of, that need that I guess it's
pernicious.
Yeah. It's I guess it's kind of used and abused. It's hard. And, when people say they get results, the issue is that there needs to be studies made that show some form of support. I'm very supportive of evidence-based medicine.
Yeah, if your philosophy is not evidence-based, then you can claim anything and get away with it.
Yeah.
It's if you're a patient who's concerned about results and probability, then the chiropractic is not for you.
Yeah. I'll tell you a story. So I was in pre-med trying to get into med school. I was in dorm room with another guy who didn't get in. 2 years later, he became a chiropractor. And he knows that the profession isn't evidence-based. He knows that it's not really providing any benefit. And he told me, he's like, oh, Tushar, you're probably going to hate me, but I'm going to become a chiropractor. And he had a smile on his face. And he knew that it doesn't provide any benefit. It's probably doing more damage than good. But he knows that you can make a decent living from it. So I guess it's a little bit scary in a way.
For the record, the chiropractor didn't help me at all. I ended up going to a Pilates instructor. Yeah. And through a combination of the reformer exercises and the Pilates massage, which is not a leisurely ordeal, it's quite a painful ordeal. The pain that I was experiencing in my ribs eventually went away and over time stayed away. Yeah. And I've had little issues with it since then. And that was as a teenager. Yeah. So my anecdote is against chiropractors. Yeah, it's to this day we don't have any chiropractors in the hospital, and we don't have anything to advise related to chiropractors. Mostly we do physiotherapy. I think that's a huge indictment on chiropractors, is that they're not present in the hospital and they're not recommended by. Yeah, we don't associate ourselves. And we kind of sometimes distance ourselves. A lot of, when I was in my neurosurgery, when I was a junior doctor in neurosurgery, a lot of patients would come with posterior vertebral dissections and bleeds into their brains post chiropractor manipulation. Now, we don't have any evidence, but when we take histories, appears to be a recurring theme, and I definitely think it should be looked into. But there is a very high risk and complications associated with it. And it's just, I mean, when you hear risks like that, I would not rather take that. Yeah. But yeah. So the chiropractors thing seems to follow on to homeopathy and the placebo effect. Yeah. So homeopathy, popularly considered to be a bunch of nonsense that somehow has a valid effect in some cases, which is synonymous with the placebo effect.
Yeah. I mean, it's a perspective based, right? Some people truly believe that homeopathy works. The philosophy of homeopathy is that basically you have an active ingredient, right? And the more dilute that active ingredient is in a pool of water, it's considered the more potent. And so they put that into a vial and provide that.
And that original active ingredient is the thing that was problematic in the first place, is that right?
Well, I don't know what the active ingredient is. I don't know enough whether they use different. Most of the time it's used sugar was one of the active ingredients, but I guess there's lots of others and mixes. But it's water based, it's dilutional based, and the philosophy is that what I know, the more of it's dilute, the more effective it is. Now, I guess when I first heard about it, and I mean, if you're hearing through the mic right now, you would probably be infuriated for the idea that this is kind of ridiculous. Obviously, it's not going to work, right? But then you have to consider the placebo effect, and it's a very real thing. It's a very, very real thing. Harvard has dedicated a specific institute or a part of its university to research placebo, how it affects the human body, and whether we can use that treatment for certain ailments. In the hospital, now this is a little bit hush-hush, but in specific situations where we know that the ailment is not physiological, sometimes we might just give IV fluid and the patient feels a lot better. For example, we have a patient who might have a factitious disorder, meaning that they're just basically making up an illness for, insidious means or attention, and they'll keep doing it, and maybe just a little bit of water saline can make them feel better.
Right.
So in very strict situations, we don't do that all the time, just making it very clear. It's noted, it's documented, and it's to help the situation, and it's not just for the patient but for the rest of the staff.
If a patient is either pretending or has legitimately deceived themselves into a condition, and there is no legitimate treatment for it other than the placebo effect, it doesn't seem too ethically questionable to me than to give them a placebo treatment. Yeah, so in that situation, and so I mean, homeopathy, you can get angry for the fact that it's not actually treating something, but you cannot ignore the placebo effect. The concern comes to where, let's say you have a active condition. For example, you have abdominal pain. Now, there's many causes for abdominal pain. Let's say you've got an appendicitis that's causing abdominal pain. Unfortunately, most unlikely, the placebo effect is not going to do much for your appendix, and if it's getting worse, it's going to rupture or it's going to need to be taken out. So there's very specific situations that need to be used for placebo, and I guess homeopathy is kind of the perfect way to create the placebo effect, because if you create the placebo effect in a medical institution, it's almost as if you're deceiving the patients. Patients have come for treatment, but you're using psychological manipulation. Whereas the intention of homeopathy is to actually treat, but as a consequence, it's placebo. So it's kind of, homeopathy is kind of like a perfect place to use placebo effect. And so maybe it's good for us. We don't know. But I guess, and I know that homeopathy doctors, with quotation marks, because some people call themselves doctors, they're actually aware. So they know that if something's very, very severe, they will recommend, and these are very, they'll recommend them to go see their, local physician. But they sometimes know that they're using the placebo effect to help someone. So there is definitely some good and some light to look into in this situation. The problematic thing that I can see is that if somebody goes to a homeopathy clinic as a primary source, if they have abdominal pain and they go to homeopathy, that could waste valuable time in diagnosing and treating a serious condition and cause...
Yeah, of course, and that's the thing. So it should be very specific conditions that should be useful.
But it would be tricky for a doctor to refer somebody to...
Of course, it can't be. So that's the thing. Doctors cannot refer to homeopathy. Yeah. It has to be out of their own will and fruition.
Yeah. So there's no legitimate way to find yourself.
Yeah, because if they did a study saying like you are receiving a placebo and you can still receive the placebo effect, which is quite interesting.
That is interesting.
But in saying that, it's again, we're going back to the fact that it's not evidence-based medicine, and there's very specific conditions I would recommend for homeopathy, and they're very small in terms of the range. It's not every single ailment can be fixed by placebo, but that's from my very limited experience. Obviously, I guess you have chronic pain doctors who might think otherwise, or you've got patients with IBS, so a gastroenterologist would think otherwise, and I think asking them, you'd get a very different answer.
How much nutrition training do doctors receive as part of their mandatory requirements?
Yeah, so unfortunately, it's really just 2 hours in the 6 years worth of training. You get 2 hours, you get taught. Yeah, you learn about biochemistry, but does that really help in nutrition? It's very, just the building blocks, but really it's just 2 hours, and then they're like, yeah, it's done.
Nutrition is obviously a very complex and large topic.
Yeah.
In 2 hours of nutrition training, what of value can you really get?
No, I think we can already agree that the amount of nutritional knowledge you receive as a doctor is so bad.
Yeah,
it's really bad, and I really think if when someone asks about weight loss advice, and someone asks, where should I go, I would personally recommend them to go to a dietitian or someone who is experienced in losing weight in a safe manner. I mean, I guess bodybuilders are one of the most experienced now. Are they the most healthiest? No, but they know the exact mechanism of losing weight. The 2 hours is definitely not enough.
Yeah, definitely. Nutrition being such an important element in personal health. Yeah. You are what you eat, in a sense.
Well, do you know what I really like? What I've noticed in New Zealand, and I haven't noticed it and something that I've found even in third world countries, is they don't have any lifestyle medicine. So what a lifestyle medicine doctor is that you go to them, you tell them literally about your daily routine, what you eat, drink, sleep, do, your stress levels, relationship with family, all of that. It's a holistic type. And they look at you, the medicines you're taking, what medical conditions you have, do a general workup, and they'll give you advice, daily changes, and how to basically implement those changes to improve your lifestyle. From all the way to eating, sleeping, relationships, changing of your medication to optimize you, right, which is awesome.
So where do they have this?
The first time I was introduced to it was an American doctor that was in South India when I was on my elective. He was in CMC college down there, and he was a lifestyle doctor and also did that in America, right, as well. So I mean, it's crazy to think. I mean, maybe I'm not exposed to it in New Zealand, but I have not heard one bit about lifestyle doctors, which I think is a massive gap. And I think there is room for it. I think a lot of people would be interested. I guess GPs have taken on that role to become a lifestyle doctor, but I mean, just the lack of training and understanding that we have. It's all very blood work based. Like, you're going to take your iron levels, we're going to take your B12, we're going to take your HbA1c sugar levels. So you take that and you say, oh, that's high. You need to cut down on this type of foods and stuff, or you need to lose weight. I mean, if you try ask lots of different doctors how to lose weight, you'll get a different answer every time. Yeah, it's definitely not
That's
right.
Concerning.
Yeah.
I find that, I believe that nutritional training should be a part of high school.
Yeah, of course.
It's such an important element in everybody's life, and it's so seldom understood. Yeah. And it is complex, so it's quite a daunting field to educate yourself on. So having a very simple, coherent lesson or class in high school would be a good way to begin. Yeah. And then people can go into the world having a foundation that they can expand upon. So yeah, the nutritional training, especially in New Zealand, is terrible. Yeah. So I have to ask you then what your thoughts are on a plant-based diet for personal health. which is with no meat or dairy or any animal products whatsoever.
So I guess we had this chat before, but if we're talking about health and we're talking about what I'm trying to say is that if you go through trying to improve yourself and trying to habitually improve your diet and improve your weight and improve your health and lifestyle, I think you'll generally move towards a whole food and plant-based diet. And I guess this is actually a personal point of view, because a lot of people have different views on this. I've lost weight on my own. I lost 17.5 kilos, and that was just on calorie counting alone. Now, was that the healthiest? No, because yes, I ate less calories than my body needed and I lost weight, but I was eating cookies. I was hungry all the time. I was eating junk food all the time. It was just under the calories I needed and I lost weight. But I felt miserable. I was waking up just hypoglycemic, shaking. It was awful. And every time I would go off tracking my meals, when I would weigh my food and measure the number of calories, I'd just flick off and I'd start eating. And I guess I actually recently learned that when it comes to healthy eating, because I'm starting to lose weight again, but in a very sustained and sustainable way. And it's the habits that basically affect, because there's such a massive pressure from the environment, pressure from other people, pressure from families, even cultural pressure to eat food and eat not healthy food. And all we want, I think a lot of people, when they want to lose weight, they don't really want to think. I don't want to weigh my food. I don't want to have to
put in effort.
I don't have to put in effort, right? And I guess if you're trying to lose weight, which is the first, and if you need to lose weight, or if you want to be a healthier body weight, and I guess you don't want to think about it, whole foods and plant-based foods is a very good start. Do I think you need to learn about calorie counting before that? Absolutely, because you need to understand what foods have a high caloric value and have low. Because even if you have a plant-based diet, you can just make fries all day or eat just rice. You need to get your calories right. Then you need to get your protein, fats, and carbohydrates right. You need to then get your the fiber and also micronutrients, which is, I think, there's lots of different pillars, and people prioritize different things, but that's kind of like the pyramid that I kind of use. And I think micronutrients is very, very underrated. I think trying to get a diverse amount of nutrients into your body in a low caloric fashion, I personally think there's only one way, and that's through fruits and vegetables. You just can't get the diversity of micronutrient profiles with other foods. And that's why I guess I've shifted more towards trying to eat that certain way. I mean, if we eat out, that's fine. I'll eat some of that. But what I'm trying to do is I'm trying to change my habits. I'm not trying to go on a diet or anything. I'm just trying to change my habits as much as possible, because that is what at the end of the day is causing it. Your repeated things that you've grown up with as a kid, or the foods that you eat, or the comfort foods you eat, those are the foods you end up re-eating again and again, over and over consuming. And so if you create these simple rules in your head, like, I'm only going to eat this, it's a lot easier, and it has to be sustainable as well. But that's and it generally pushes towards that idea. Now, am I against veganism? No, absolutely not. And the reason why is because what I just discussed is it pushes towards that idea of eating a more diverse micronutrient profile that's low in calories. You can still be a vegan and still eat quite high calorie food. Don't deny me on that. But when you educate yourself enough, you can move yourself towards that diet. I guess every type of lifestyle has its difficulties, and trying to get enough iron, B12, those things can be still quite tricky. And I think if you're aware about it and you compensate with supplementation, that's completely fine. I'm not going to hound or punish someone. Basically I will, if someone asks me on a diet and what I think about it, I think about it in, is it sustainable? Because a lot of people do keto or OMAD, things like that, and they have great success, but a lot of people can't do keto for the rest of their life. They can't live outside of their homes with just a keto diet. Things like it becomes very, very tricky. And so sustainability is very, very high on basically my list for what to do and what to eat.
Yeah, you bring up some interesting points, and something to clarify from my perspective, mostly for the listeners, is a key distinction between a plant-based diet and a vegan diet. Yeah. In that, well, mostly a vegan diet is more likely to be unhealthy because a plant-based diet is actually more restrictive than a vegan diet. So what I mean by that is the vegan premise is no animal products for ethical reasons. Yeah. Whereas the plant-based diet is, or a specifically whole food plant-based diet, is no processed or minimal processed foods and refined foods. And it's about whole fruits and vegetables. Yeah. And so a vegan can still have fried food.
Absolutely.
Sugary foods and things like that. So the plant-based diet is more keenly focused on nutritional food. Yeah. And I find that the conversation around the plant-based diet tends to be attacked from objectors to the diet. They tend to focus on attacking the vegan premise and not so much the whole food plant-based part, whereas the vegan conversation is more fit for an ethical debate, whereas it's the plant-based diet that people need to
but in saying that, you can still be overweight on a whole food diet. Like it's just calorie consumption. If you're eating if you've seen a diet of a sumo, they eat extremely healthy foods. They eat fatty fish, lots of rice. Some would consider minimally processed foods, and yet they're extremely overweight. Their whole job is to overeat. Yeah. And they're told at a very early age that they're going to die quite young.
And despite eating reasonably healthily, they're not healthy as a consequence.
And it's just because of their weight. And so, a lot of people fixate on losing weight to being healthy, and I guess there is some premise on that, because losing weight will decrease your lipid profile, to decrease your blood pressure, or decrease your blood sugar. It will decrease the amount of load that's put onto your joints. So it's a very good start, but it's not the end all be all. You need that. You need sustainability. You need micronutrient profile. You need a good range of fats, protein, carbs. You can't just be like, all fats. Your body needs all three. They all have a function. Yeah.
I guess I should, because we pointed out how poor the nutritional education is for doctors, and then we went on to talk about nutrition. Yeah. So we should probably elaborate on what extra work you've done to educate yourself on. Yeah.
The reason why I guess I know a lot of weight loss is because I've lost weight myself, and I guess it was I learned a lot of biochemistry, so very, very the minutia
as part of medical.
Actually, I was in biomedical science in my first year, where I learned biochemistry, and I learned the minutia of nutrition. So building blocks, the Krebs cycle, all this molecule by molecule metabolism, and so I've learned at a very in-depth level. But then when I started losing weight, in all honesty, there was a lot of YouTube videos and a lot of experimentation. But what helped me is because I learned so much of that biochemistry, I could apply it. And what I think doctors lack is that when someone's asking, hey, can I lose weight? I guess they know the theory at a very detailed level, but there's no application involved, no way to apply it in lifestyle. There's no way to, because what you want to do is, what's the easiest way I can implement this in my daily life and basically do it forever?
Well, typically the answer to that question is there a pill to satisfy the needs?
No, I don't think there is I think there is a pill. We take a multivite that has, and also like a drink that has enough calories with a macronutrient ratio.
That also fills you up.
That also fills you up. I mean, you could technically create that. But what's very interesting about that is because if you see patients that are very severely deprived of nutrition, let's say they've got a esophageal cancer, they can't eat, they are on the specific IV nutrition. It's called TPN, total parenteral nutrition. And basically it's this bag. It's photosensitive, so it's a black bag, and then it goes down and it's just injecting into your vein and you're given it. But you see very quickly that even these patients that receive that, with the enough calories they receive, they might have some benefit, but the psychological aspect of eating food isn't there. Obviously, I'm not very experienced, and I think a dietitian will have a better better person to explain this. But from what I've seen with some of the patients is that there's no satisfaction with this. There's no benefit, and there's a little bit of depression when it comes to not being able to eat the food, and it's just being injected straight into your body. The absorption rates are not as effective. Now, for example, vitamin D, the tablet, there's been some inconclusive data where they actually say that the absorption of vitamin D as a pill is not really effective.
Interesting.
Yeah, and so I don't think we've really cracked the code of you can take a point, and I don't really think there's such a massive cultural and societal aspect and that brings people together with food that I think we shouldn't really ignore. Have companies taken advantage of that and create to the point where we've had overconsumption? Absolutely. But we shouldn't absolutely hinder away, how many families these days don't even eat on the dinner table anymore and just eat in front of the TV or just run a smartphone.
Yeah, healthy eating habits being a key factor in nutrition.
Yeah.
So not even just what you are consuming, but also how you are consuming it.
Yeah.
And so it's important to, from a psychological perspective, food is certainly can be enjoyable. Not for everybody. There are obviously conditions that get in the way of that.
Yeah.
But the enjoyment of food can play a key role in healthy eating. And I can actually give an anecdote to this. I used to really not like vegetables and leafy greens and things like avocado and mushroom. I just did not like them. And after going vegan for ethical reasons, I was exposed more to these foods and less to meats and dairy. And my taste preferences changed and evolved to now to love eating avocados and mushrooms and leafy greens and salad things. And so I get just as much enjoyment out of this now far healthier meal as I did, if not more, from the meat meals. And I recall really enjoying those meals. And I really enjoy my food today. And it's way healthier as far as I can tell. So that goes to show that sensory pleasure we get from our unhealthy meals can be kept while improving the nutritional quality of the meal.
Absolutely. And it's interesting because if you look at fast food, they've kind of perfected the art of delicious food that's particularly not filling, that you want to crave more of, and it creates a repetitive cycle. And when you're eating just that type of food, that's kind of all you know. And when you eat that type of food, you don't really want to like fruits and vegetables. And it's very difficult to break away from that type of, which one would say addiction or not. I mean, it's hard to say, but it's a very addictive food. But transition from there and then start to enjoy that type of food again, or just even a new type of palate. And it's really interesting, I guess, trying to find out the psychology of changing or rewiring your brain or your palate to different sorts of foods and acquiring it.
It probably takes time and a lot of self-control.
Yeah, and some people just don't want to take a bar of it. Some people just don't believe that they like fruits and vegetables. I mean, I know people that don't like drinking water.
Yeah, same.
And
wild.
Which is insane because we need water. I've seen patients show up to ED and they're dry, probably stuffed up their kidneys because they haven't drunk enough water. We have to give it IV. And they say, I've just haven't been drinking water. And they take like water tablets to stop them from fluid overloading for their heart condition.
A water tablet.
When I say water tablet, what that means is, it means to help them pee. That's what we tell our patients. Okay. That's not literally a water tablet. I
was imagining a capsule with just water in it and you swallow it with your Red Bull.
It's a very, very interesting thing, and I guess we don't really know the explanation of like people who don't drink water. That's a very strange thing.
Yeah, not liking the taste of plain. It's a interesting thing I cannot imagine.
Yeah.
I'd like to talk about the overworking of medical staff. In general, but also of late due to COVID. In the news, there's been the nurses' union going on strike for underpaid, overworked conditions. So what do you think about that?
So do you want to go specifically with nurses first?
We can do whatever you like.
Okay. So obviously I'm not a nurse myself. I only know by secondhand what I've seen. But I guess the situation currently is that the number of nurses that are needed in a ward, basically there's not enough. They're often overstretched, and the amount of pay for the number of hours they do is ridiculous. And I guess within each ward, there's a different level of intensity. So for example, if you're doing pediatrics or you're doing ED, you're doing 12-hour straight shifts. Now you do those for 3 days, from what I understand, and then you get 2 days or 3 days break and you go back on. So you do 12-hour shifts. Now this might be a night shift or afternoon shift, morning shift. And that's different from a ward-based job. But the issue is that they're all getting paid the same. So in ED, you might be cranking out 12 straight hours as a nurse, full-time, not probably get some protected hours of 15 to 30 minute tea breaks and lunch breaks. But you don't get that in the ward. A ward is a lot flexible. It's a lot more relaxed, but you're getting the paid same amount. On top of that, the pay itself is not enough, and on top of that, burnout is quite high, and there's not as many nurses, and so you're stretched. So one nurse may have to look after multiple patients or even more patients that they should have, just to make up for the nurse that's not available at the time. And so all those factors kind of play together to cause burnout. I know a lot of nurses that are kind of frustrated at the fact, and they don't get paid enough for what they're doing. And there's a lot more attractive opportunities outside of New Zealand. Australia is a perfect example of that. There's a massive exodus, what I know from North Shore Emergency Department. It's already happening where we have a massive shortage of nurses, and we're asking the nursing bureau to replace them, and we're not. And they were all stretched, and everyone's just leaving for Australia.
So there's kind of a luck of the draw in that the same one nurse might be working in a less intense situation than another, and they're getting paid the same.
Exact same, yeah.
Right.
And it's absolutely frustrating.
A luck of the draw system, or can you choose?
Well, no, you can choose. You can choose as a nurse, and it's based on personal preference, right? Some nurses like action. They like doing something straight away. They like short-handed tasks, and so that is more applicable to ED, where it's a little bit more laid back. Let's say in the rehab ward, and it's a lot more focused on mobility and getting someone back to original shape. Whereas it's a lot more acute presentations in ED.
And how has COVID affected this?
So COVID has created for workload in the hospital. You'll be surprised that, well, for me, it's been... Do you want to talk about nurses, or do you want to talk about doctors in this situation?
We should talk about doctors here, because they have more first-hand experience.
Yeah. So conveniently, if I was working inside the hospital, meaning in the wards, it was a fantastic time. And the reason why is because, number one, all elective surgeries got cancelled. So elective surgeries are surgeries that aren't urgent and that can be booked a spot, and then patients get called in and say, hey, look, you have your surgery this day, and they'll spend some time in the ward and they'll go home. So, for example...
Non-urgent.
Yeah, non-urgent. So like your tonsils are big, you're not sleeping properly, and they need to be taken out. It's not an emergency, so they can stay at home, and then when the time is right, they can come and get it removed.
Yeah.
And so all those got cancelled because of COVID, increased risk of transmission. All those surgeries got cancelled. That basically decreased a massive load in the surgical wards. On top of that, at the beginning, not patients, but people, the general public, were quite fearful of showing up to the hospital, because if there's one place you're going to catch COVID, is the hospital.
Yeah.
So it was actually really good. But in saying that, it was awful down in the front line. So what I'm saying front line is the entrance into the hospital. So emergency department is basically kind of the gatekeepers of the hospital. So when patients first need to get inside the hospital, they have to go through ED. So they'll be triaged which specialty they need to go to and what care they need. And so lots of concerns about COVID, complications where they think might have COVID, and then there's logistical issues with patients there. So if someone comes in and says they've got a cough, and now you've got a dilemma because they're not swabbed, you don't know what they have, and you need to give them a negative pressure room. So that's one room for a person who's just got a cough, a negative pressure room, which is basically a room that's sucking up all the air. So if you cough or release anything, it's sucked into a vacuum, so it doesn't spread anything. But those are very expensive rooms. Just for a cough that we don't know, we have to wait for a swab 1 to 2 hours, and then we can clear them, and then we can bring them back out. So that's a massive load that takes up one for just a simple cough, shortness of breath, fever. So it's a big issue. So they take up quite a lot of space. And this whole idea about basically, if beds are taken up by these patients, if other people who are really sick won't be able to get a bed because those beds are already filled up.
By the people who just have a cough.
Yeah.
So going back to, you said they closed down all elective surgeries. Is that in an effort to reduce the number of patients coming into the hospital?
Yeah.
Or is it to free up medical staff for other areas?
No, so it's not that. It's truly to prevent any spread of COVID. So less people in the hospital is less risk of spreading. So even like everywhere we went, we had to sit, further away. We had to be in PPE in some situational areas. So there were measures made in order to stop that.
So what do the elective surgeons do?
So the surgeons do both. So they'll do acute surgeries and we'll do electives. And so there's two lists going on. There's the elective surgery list and then there's the acute list. And so there's this one theater that's left behind just in case anything happens. So let's say we're in general surgery in the trauma unit. There's a dedicated theater that's left behind for, let's say, bullet shot wounds, or someone's ruptured their appendix that's very, very sick. So there's always that space available that someone can be slotted in really urgent situations when everything's full. People with elective surgeries have to be bounced, and then that person will go in front.
What's bounced?
Like the elective surgeries. In that case, if elective surgeries were happening, but obviously in COVID, that wasn't the case. But I guess the consequence of cancelling all of them is that there's a massive waiting list now, and they've got to play catch up. So as everything's kind of getting back to normal, you've got thousands of people waiting, and that's creating a massive backlog. So people who've been waiting for 3 months now being pushed to 8 months, and it sucks. It really sucks for them.
How has the hospital system more broadly handled COVID?
I have to say, New Zealand has done as much as it can with the money it has. And it's done, some hospitals struggle more than others. And I have to say, me being in North Shore and Auckland City Hospital, it's done relatively well. You have some issues here and there, like for example, in Middlemore, there was a patient and they were COVID positive, but no one knew yet because the swab was waiting. Unfortunately, this patient was in a 4 or 5 bedded room in ED, and basically they were isolated with just curtains, and there was no negative pressure. And so all the doctors that came in contact, the patients that were adjacent, all the nursing staff that were adjacent, that were in close contact now, had to take time off, get a swab, either get it negative or be in quarantine for 2 weeks if they were tested positive. So there are flaws in the system, but I guess I'm trying to be grateful relative to third world countries that just don't have the ability to do all the spacing, have specific rooms for COVID patients, triaging systems with on top of COVID patients. So I personally think they've done as much as they can. New Zealand is not a very, I think they're very reactive. For example, one thing that was really important to really get across was having enough intensive care unit beds. New Zealand itself as a whole just doesn't have enough intensive care. And this was before COVID. Then the patient load is too much, and we've always needed more intensive care unit beds. North Shore did a fantastic job of actually making their elective care hospital that's separate into a COVID dedicated hospital. And so that was really, really good to create more and more bed space. But basically the reason why we were doing it is because if COVID took off and the number of very sick COVID patients went up, we would have the ICU beds, or we would have the facilities to compensate for them, but we'd never reach that severe level. Sometimes we'd be stretched, but never to the point where where we really needed it. I was in respiratory 2 years ago, and I had also signed up to the COVID team doctors. But we never got to that situation where I had to lose my position and change to a COVID doctor team because it didn't get that bad.
So they always had backup capacity?
They had backup capacity. Now, was it enough? We don't know, but it was as much as we could do.
Well, New Zealand was lucky in that we did minimise our exposure to COVID, at least thus far, by doing early border closures and lockdowns. Yeah. So I guess we don't know the full extent of how we could be hit by a more severe pathogen or wave of COVID.
Yeah.
Well, that's probably a pretty good place to leave it. I think we covered everything we planned to.
Yeah.
So
thank you for your time, Ryan.
Thank you. Cue jingle.